preventive and therapeutic measures. For example, we can say either the test which is used for screening, a good one or maybe not very good one, is a therapeutic method, a method of treatment, is it suitable, or maybe it has a lot of side effects. So this purpose, number 4, is also crucially important for clinical epidemiology. So finally, all this, what we have mentioned, is the basis for public health policy. And when we say that epidemiology is a basic fundamental science of public health, we mean that information given by epidemiology serves as a basis for public health policy. Okay, so what is the fundamental assumption? In epidemiology, there is a very important assumption which we cannot miss, is that diseases are not randomly distributed in a human population. So the fact that somewhere diseases are common and in another place the same diseases are rare, it is not by chance. The main assumption of epidemiology is that there are some factors, there are some reasons which predetermine these differences. And if we know that diseases occur for some reasons, that there are some important factors which can serve as exposures, or we can call them risks, we must study these differences in the populations. Okay, there are two main areas of epidemiology which we will discuss, and we cannot say that one is more important than another one, but they are absolutely equal, and they are equally used as a tool for research in the field of health of people and diseases. And those two parts of epidemiology are descriptive and analytic. Well, if descriptive epidemiology is used at the beginning of any epidemiological investigation, analytic study is more applicable when we have already some information. So the basic difference between descriptive and analytical study is that descriptive study is used when we have little information about the disease, while analytic study is used when we want to learn some details or some maybe specific aspects of a disease. If you want a descriptive epidemiological study, you will not try to get a lot of information and new data. We will usually make reasoning on existing data and rely on those sources which are available at the hand. If you want more deep, more profound understanding of a disease pattern, we will develop our system of searching and collecting of data, and usually we will try to collect some new data. The questions which we can answer by descriptive epidemiology is who get a disease, where people get a disease, when people get a disease. For example, we will show distribution of the disease by age groups, by gender groups, by places, by time. And if you want to answer the question, is the disease common in summer or in winter? That's for descriptive epidemiology. If you want to answer the question, who got more a disease, the rural people or the urban people? That's a question for descriptive epidemiology. Analytical epidemiology has more difficult task because it answers the question why. And we try to understand why people in rural areas have more disease compared to people in urban areas. Or let's say why the younger people are less predisposed or susceptible compared to the elderly. Well, so if you sum up, try to summarize this understanding of approaches in epidemiology, you understand that in descriptive study, we can hardly get ideas about possible associations, particularly causal associations, while analytical epidemiology enables to draw more difficult and more complicated chains between the studied phenomena and our potential explanations. Okay, if you look at the stages, how we usually run an epidemiological study, we always start with the methods of descriptive epidemiology. So we ask the question, how is the health-related outcome distributed? Then we try to say, well, if we know how the disease or outcome is distributed, can we have any hypothesis explaining these facts? And if we manage to generate a hypothesis, we will try to test it or to check it. So then we will need the tools of analytical epidemiology. In analytical epidemiology, we will try to establish associations. We will measure different kinds of parameters to draw a conclusion about exposure and outcome, how they are related to each other, and probably how the outcome is predetermined by the studied exposures. If we want more explanation for the associations, we will try to check probable causal associations, and then we can make a design that enables us to prove that the fact is not just associated, but it is a causative factor. And finally, we will make decisions which can be applied for communities or for individuals, and we will try to evaluate either this theory was true or false. So finally, after we prevent the outcome, we will evaluate how successful was our work to draw a conclusion about intervention. So this scheme is quite complicated, but it is really universal. It can be used for any problem, for any disease. Doesn't matter if it is infection or not infection, if it is a trauma, external condition, or internal, like genetic disease. We can use these steps absolutely for any epidemiological study. Now we have to discuss the main types of epidemiological studies. So according to this scheme, there are two main types of epidemiological study design. Sometimes you can be confused with the term epidemiological because partially some of the studies belong to clinical group of studies. But let me explain you and ensure that it's not a mistake, it's not a kind of misunderstanding, because epidemiological study is a very broad term and we use it for clinical questions, we use it for social questions, we can apply it absolutely for any medical problem in the community, and to some extent even not to purely medical problem, but even for complex problems that are affected by a number of external factors. When we classify epidemiological studies, there are two categories which we distinguish, and we can call them experimental and non-experimental, or we can call them observational and interventional studies, or you can use any other terminology that is accepted in this subject. However, we got used to the term experimental study or intervention when we have some intervention for subjects, and we use the term observational when we don't have any intervention for subjects. So the crucial difference between these two types of studies is that in interventional study, we can have some applications for subjects, we intervene, while in observational studies, we don't intervene and we don't apply any kind of experimental intervention. Well, the first group which we will discuss will be experimental study design, and you will understand why. The main reason is that this study design is proved to be the basic one for evidence-based medicine, and while today we suppose EBM, evidence-based medicine, one of the main sciences in present medicine, it's one of the main directions in development of medicine. So we suppose that experimental studies must be the basis for any investigation and for any kind of research of the problem. Okay, so if you look at non-experimental studies, there are a bit more, there are more categories, and I can say that they are also used a lot, though there are some limitations in using of both of these study designs. So sometimes we are limited in use of experimental study. In other cases, we are limited in application of observational studies. Still, if you look at two groups into which experimental studies fall, they are controlled randomized trials or non-randomized, what we call quasi-experimental community field trials. And the crucial difference between them is the word here, randomized or non-randomized. In other aspects, they have a lot of similarities, and they doesn't matter if it is randomized or non-randomized, they have intervention which we will apply. If you look at group of observational studies, the main difference in two groups of studies is either it is population-based or individual-based study. In most of cases, in clinical practice, we have individual-based studies when we look at a patient or a particular case or a particular person. And here we have mainly descriptive purpose, and we can use either case reports or case series reports. If we have analytical approach, but also in individual-based study, it will be a limited case control study or case reference. If we use population-based approach, we can study different parameters, both for descriptive purposes by surveys and ecological studies, or use analytical approach and use cross-sectional case control and cohort studies. Now, if you look in a unit of study, which is the first column, you can see that population studies are ecological studies, and patient studies, experimental. If we look at individuals as categories of studies, they include all other study designs like cross-sectional, case control, and cohort. In the literature, there are different terms which can be used for this scientific and generally widely accepted terminology. For example, instead of ecological, we can say correlational studies. Instead of cross-sectional, we can say prevalence studies, and cohort studies can be called follow-up or longitudinal studies. Okay, experimental studies, it's the first group which we will discuss. We must say in the beginning that these are very powerful studies for testing different kinds of hypotheses, that they are really very good in proving hypotheses, but for ethical reasons, we are not able to use always experimental study. For example, if we know that ultraviolet radiation is potentially dangerous and can lead to skin cancer, we cannot take a human and intentionally expose him or her to ultraviolet radiation. It is not ethical. So for this reason, for humans, application of experiments is quite limited. However, when we exercise control over allocation of exposure, we can be absolutely sure that that's our exposure led to the studied outcome. And for this reason, experimental studies are used a lot for biological models. Okay. Still, in experimental study design, we can test efficacy of treatment, we can test efficacy of vaccines, we can study either intervention for community is helpful, for example, some educational program, or maybe some intervention like the use of seat belts in the car, or to study fluoridization of water, and so on. Different techniques for experimental study design distinguish some peculiarities of this design. Let's say we can have controlled study and non-controlled study, randomized study and non-randomized, double-blind. I talk about this now. The first study design in experimental group is obviously pure or laboratory research. It's really important to remember that we must be very grateful to participants of pure experiments, which are often becoming victims of researchers, but without them, it's hard to conduct any experimental study. I talk about animals like rats, rabbits, some others like dogs or cats. These animals are used to study any pathological condition, except situations when we are not able to reproduce a disease in the animal, for example, HIV, human immune deficiency. If we talk about laboratory experiment, it can be obviously conducted in vivo and in vitro. If we don't have opportunity to study a disease in vivo, we will study it in vitro as well. Still, in pure experiment, the idea is to induce a disease artificially by making a kind of biological model, and we have the task to make a disease process very close to the natural one. It's typically done in communicable diseases when we know about infectious agent and we can reproduce the disease in the animal. So after this, we will study a disease process and we can test any intervention like a vaccine or a drug or a surgical treatment, and this will be obviously used for our epidemiological reasoning. If we study a cause of disease, we can also easily induce a disease in the animal, and if we prove that the biological agent is specific, so it doesn't lead to any other diseases, and that will be the way to prove that the disease is caused by this specific agent. In a clinical trial, we have to involve people, human subjects, so they must be eligible for participation. And you see, it's really a problem when we have a lot of people in the community, but we have to enroll those patients who are really suitable and eligible for participation. In most of cases, eligibility is determined by diagnosis and by specific characteristics like age, gender, or some pathological conditions which can accompany any disease. In clinical trial, we involve people, and if we have a comparison group, we will call it controlled trial. If we don't have a comparison group, it is called uncontrolled trial. Still, it doesn't matter what kind of trial we use. Clinical trial is recognized as the best justification for concluding causality, and for this reason, it's recognized as a gold standard in medicine. Obviously, the controlled trial is better than uncontrolled because in this case, we will compare either a drug and a placebo, or we will compare a drug with another drug. So you can see that a design of a clinical trial, it usually starts with randomization when subjects are randomly allocated to group 1 intervention and to group 2, which is called control. And after this, we will measure outcomes. If randomization itself is difficult because it requires minimum participation of the researcher in the allocation of treatment. And this is difficult because patients, they can require different treatment. However, we must remember that in epidemiological research, we don't have the purpose to give the best clinical service for the patient. We have another purpose. And then randomization is done not in the interests of a patient, but in the interest of the study. This is the scheme which shows you an example of a randomized controlled trial when we have two kinds of interventions, for example, aspirin and streptokinase, and compared with simvastatins with vitamins. So one group receives the first intervention, control group receives the second one. And after we finish the study, we compare the results. Very often, method in a study design is to give a placebo or inactive drug, which looks like a drug. It can look like injection, it can look like a drink, it can look like an ointment. It depends what you study. But placebo, the word, it means inactive, yeah? So it doesn't have any positive or negative effect. And it has only one purpose, to make patients blind for interventions, in order patients not to know which intervention they receive. And from psychological point, a placebo enables us to be very just, to be very honest, and to have minimum of probability for mistake. So a single blind study is the one where patients are blind for intervention they receive. In other words, patient can receive a drug or receive a placebo. They don't know which one they take. If we talk about a double-blind study, it means that a doctor is also blind for interventions which are received by patients. And we say neither the researcher nor the participants know who receives a placebo or the real treatment. Double-blind studies sometimes are not possible to conduct. For example, there are situations when you cannot make patients blind because patients understand that they, for example, take some intervention. In this case, blindness is impossible technique, and we understand a potential risk of subject bias. Crossover design is a technique which is used the same subjects as intervention group and control group simultaneously. Of course, simultaneously doesn't mean that a patient takes two drugs, a placebo and a drug. No sense. Or takes drug 1 and drug 2 because they can interact with each other, probably. So in crossover, we have so-called repeated measures design. So subjects first take treatment 1 and then control treatment, or control treatment after then treatment 1. Or they receive treatment A, after which treatment B, or vice versa, treatment B, then treatment A. You understand that in crossover study, we have very good situation when every subject tries both of interventions, and we can be sure that this is ideal comparison because subjects are absolutely the same. In randomization, we must always check if the subjects are really very similar with each other or they are still different. Crossover design has a peculiarity which we call ideal matching. In other words, every subject is matched to himself or herself, and each patient receives both interventions. Doesn't matter if it is an active treatment or it is a placebo. Well, however, crossover design is not possible to be used in any situation, and we say that it's suitable only to study chronic conditions, but not acute. Crossover study requires less participants, so it can be used to study rare diseases. It requires longer time, and a disadvantage that we have to mention is that possible carryover effect from the previously taken treatment can make effect on currently taken treatment. And this carryover effect has to be taken into account. In a clinical trial, we have many stages, and you know that, let's say today we discuss a lot why coronavirus vaccine is designed for so short time. So the reason is that we need it as quickly as possible. However, it's not typical that a clinical trial takes 1 year or even less than 1 year. You can look at phases of a clinical trial. So it starts with the laboratory research, then continues in animals. Then we have a study which is called zero in a single patient or in single patients. And then we try in small number of patients, more patients, and in the large group. So obviously, the process of investigation can take up to 10 years until a new method of therapy will be marketed, but in some cases we can make decisions about marketing even before the study has finished. So that's the case of vaccine against coronavirus. Still, you can see that even after stage 2, we have quite good understanding about efficacy and side effects. However, phase 3 usually enables to be very sure about real effects of intervention. Okay, so usually before registration, we cannot use any intervention, but phase 4, you see, it's possible to be conducted after official registration. So the process of drug discovery and evaluation, it's a long-term process, and we have a possibility to test any hypothesis in a relatively short period of time, but the whole process will be really time consuming. Okay, then we come to community trials. If in a clinical trial we deal with patients, in a community trial we deal with populations, or we call it a field study. In a field study or community, there are a lot of people who potentially can participate. So we usually study interventions, usually like vaccination or iodization of products, educational programs, or some other interventions. And the good point about community studies or community trials is that we can check how the effect from intervention is produced not at an individual level, but a community level. For example, if you study vaccination in a clinical trial, we see the result in vaccinated people only. If you try vaccination program in a community, you can see how non-vaccinated people seem to be protected by the herd immunity because they live among vaccinated community. So the second part, we come to observational studies, and those are studies when we don't do anything, we just observe, and we can just register the parameters under our study, and by this make analytical conclusions. The first type of observational study is very simple. It is called case reports or case series. In other words, a case report gives a summary on individual or a group of individuals with the same problem. It can be the same diagnosis, the same condition, the same syndrome, because sometimes we are not sure that it's a diagnosis. Still, we try to describe in a very detailed way those individuals, and usually we aggregate cases from different sources. So you understand that a case reporting is used to generate hypotheses, and usually we use it for new problems, for rare problems, and it's not suitable to use it for something which is already known or very typical. The main limitation in a case report is that we cannot apply statistics. Okay, maybe we don't like it, but statistics is helpful, and only by the use of statistical associations we can make a summary on data. So that is why a case report is not applicable to study disease frequency, and we cannot study exposures that are typical for many individuals. Another method, which is generally we call it survey methods, but survey methods are used in any epidemiological study. So I just have to say a few words that the surveys are used to ask people about information which we don't find in a medical record. For example, people don't have to report to the doctor some details of behavior, or they don't report their attitudes, they don't report their practices. And then we have to ask special questions which are designed for surveys. Surveys can be administered by mail, by telephone, by online, or face-to-face. I would say today the most popular is online survey that is relatively low cost, it's fast, and it has very high efficacy. And particularly what is convenient is that data are entered directly, and we can reach a lot of people who are not accessible for us maybe in another situation. However, traditionally, yeah, we used telephones, we used mail, we just came to hospitals or clinics and talked to people. And this is also used to make a survey. So some surveys have low response rate, and it's a real problem when people just refuse, they don't want to answer. Some people don't give true answer, which is also a problem. And sometimes we have a problem in finding the subjects which are presenting a target group. For example, you want to ask something from intravenous drug users, but it's difficult to meet with intravenous drug user if you don't go intentionally in the place where you know they have this practice. But let's say if it is illegal, yeah, if it is considered to be a criminal act, you cannot reach them. It's a problem, yeah. Or let's say if the woman if women perform illegal abortion, and if it is not allowed, how can you reach them? It's a problem, yeah. It's a question which is difficult to solve. Okay, so that is why if you start talking about analytical studies, the first study design which we have is called a cohort study. A cohort study is one of the most powerful study designs. It is called prospective, and the most important point is that we start from exposure and we follow up until the outcome. And a cohort study has a follow-up over the certain period of time during which the subjects are expected to develop a disease. In a cohort study, the idea in the beginning, yeah, of the epidemiological research is to identify either subjects have exposure or they do not have exposure. So only after this identification we can follow subjects through a certain period of time, and after it has finished we estimate the outcome status. So we expect that exposed subjects will develop a disease, or maybe they're more likely to develop a disease, while non-exposed subjects will be less likely to develop a disease. So examples of prospective cohort studies are a lot because they are really used much in epidemiology. For example, a study on nurses when they were identified according to their body mass index, and they were followed up until they could develop such outcomes as cancer or coronary heart disease. So the idea of a prospective study is to identify exposure at such moment of time when it becomes crucially important for the development of outcome. Otherwise, the follow-up period can be extremely long, and technically it will be very difficult to follow up if we know that exposure has not contributed much, and probably we will prolong the follow-up as much as possible. So in cohort study, we identify the cohort like smokers and non-smokers, and after some period of time, we will see if smokers developed outcome and either non-smokers developed the outcome. So one of the ways to solve a problem with time consumption is to make a retrospective cohort study when we identify exposure after some period of time. Let's say if we investigate the certain chemicals and their exposure in a workplace, we can identify this fact after some years, let's say after 10 years. So then we will see from this point of time, we will follow up for another 10 years to see how much the risk of disease or maybe risk of death is different in a group which had exposure to the chemicals or in a group which didn't have exposure to the chemical. Так, okay, so in other words, we can call it a retrospective or historical cohort study. Так, okay, now let's have a break. Okay, let's have a 5-minute break. Okay, so in 3:55, we will continue, okay, to have the second part of our lecture. So while you have a break, please, leaders of the group, you can write for me those who are present, who are absent, okay? In the chat. Thank you. Okay, let's continue. Well, so we finished here talking about cohort study, and retrospective study design is one of the ways to spend less time for an epidemiological research, but to get the same advantages which we usually get in a cohort study. The typical example of a cohort study that was conducted for the period of time around 50 years, it is called the Framingham study. It's a famous follow-up cohort study that took people with hypertension and evaluated many risks like blood cholesterol level, tobacco smoking, use of alcohol, physical inactivity, body weight, and others. So the idea was to find out, to detect the risks of coronary heart disease. And in the Framingham Heart Study, original cohort included 5,209 men and women aged 28 to 62. So they were followed up from 1948 until 2008. Moreover, it continued with the third generation that is already that included offsprings and children of those people, grandchildren of those people. This study was recognized as one of the best long-term population-based studies. Let's say here you see the association between serum total cholesterol and incidence of coronary heart disease, and it's the evidence which was published in American Journal of Medicine to say about importance of serum total cholesterol control as a risk factor for coronary heart disease. Well, in other aspects, besides time consumption, cohort studies have a lot of advantages. They have minimum of systematic methodological errors, and they are the most reliable in terms of validity. And we say that cohort studies are the best to estimate direct incidence of diseases or direct risk. So that is why from observational studies, cohort studies are the best, the most powerful, and give us the strongest evidence for associations. However, sometimes we are not able to apply a cohort study. For example, if we have a rare disease, or if we don't have so many subjects to study, the alternative for a cohort study will be retrospective design, or design which uses the approach to the past of the subjects, and we call it a case control design. In a case control design, a study begins at a moment of time when people already have a studied outcome. For example, cases, they have a disease, and comparison group, a control group, they are free from disease. So then we look back in the past of the subjects and we check either they had a factor that potentially presents exposure or they didn't have this factor in the past. Obviously, a case control design is difficult because we have to check the past exposures. And sometimes these past exposures are forgotten by people. Sometimes these past exposures are not reported by people, and we have a problem of information bias. So the differences between case control and cohort studies are summarized in this table. So you see that case control study proceeds from effect to the cause, while a cohort study proceeds from the cause to effect, which we call directionality. Directionality of these study designs are absolutely opposite. The second difference between these studies is that case control study starts with the outcome or a disease, while a cohort study starts with people exposed to risk factor or suspected cause. And this is important because it means that in cohort study, we can identify people by the studied exposure, while in case control, we identify subjects by the studied outcome. The next difference is that case control study tests whether the suspected cause occurs more frequently in people with the disease compared to those without a disease. In a cohort study, we test whether disease occurs more frequently in exposed compared to non-exposed, which is absolutely a different approach. Case control study usually uses the first approach to the testing of hypotheses, but can be used for exploratory studies. Cohort study is reserved for testing or precisely formulated hypotheses. About the number of participants, it's a crucial question because sometimes it's very difficult to have more subjects. For example, if we don't have patients with a specific outcome. However, in cohort study, we need more people. And for this reason, technically, it's more difficult. It's more complex study. In a case control, we need less subjects. So we have less participants and it will be easier. In case control study, the results are very fast to receive, and in a cohort study, it will take years or maybe decades. So for these reasons, case control study is suitable to make investigation of rare diseases, and cohort study is inappropriate when disease or exposure, any of them are rare. So estimation of risk, it will be our next lecture, but I will say that direct estimation of risk by incidence is possible in cohort study only, while in case control study, we have estimation of risk by a special method, which is called odds ratio. And finally, we say that cohort study can use information about more than one disease outcome and can get this information, while case control study can get information about diseases other than the selected for study. So the preferences of epidemiologists will be usually in favor of cohort study, but they are more expensive and more difficult to conduct. So finally, we come to the last cross-sectional design, which is called a study taking a picture at this point of time. So in a cross-sectional design, we have study population, and we don't differentiate either we have a exposure the first or a disease. We will estimate both at this point of time. Cross-sectional study to some extent is descriptive and can hardly be recognized as analytical, or to draw conclusions about associations, but with some limitations. So these limitations must be clear. So if you make a kind of hierarchy or ranking according to increasing knowledge about a disease or exposure, you have to start with descriptive studies, then we have case control studies, then cohort studies, and finally clinical trials. So the development of hypothesis starts with descriptive study. Investigation of relationship to the outcome will be done by a case control study. To explain and to define its meaning with exposures is the task for cohort study, And to test experimentally association, we need a clinical trial or experimental design. So you see how complicated is the scheme of applying different study designs from perspective of public health. So the evidence hierarchy of epidemiological study design, it looks like a triangle when we have in the bottom case reports, case series, ecological studies, I will say about them. After this, cross-sectional, case control, retrospective cohort, prospective cohort, and in the top, randomized clinical studies. Just one point, I have not paid much attention to ecological studies, or we call them correlational, but ecological studies are conducted in groups, so it's a population-based study. For example, we investigate how much sugar people consume in different countries, and then we check the incidence of, for example, insulin-dependent diabetes in those countries. Ecological study is called correlational, so we try to see association between sugar consumption and incidence. But honestly speaking, ecological study can just give us associations at population level, and we cannot use the findings for individuals. They will be still checked and tested in experiments. So if you analyze this hierarchy, you see that weight of evidence grows and achieves maximum in the top with the randomized clinical studies. However, case reports, case series, and ecological studies, it's the basis of descriptive epidemiology. So that is why we have a lot of, they give us basis for analytical epidemiology, cross-sectional case control, and cohort studies. And after we are absolutely sure, we can make experimental design to find causality or to establish causality in a clinical or in an experimental pure study. Okay, now I just wanted to say a few words that traditional epidemiology today is replaced by new directions. What do I mean by this new? You know, today we have social epidemiology, infectious disease epidemiology, non-infectious disease epidemiology, behavior epidemiology, and even something what is really very popular is called genetic or molecular epidemiology. So if traditional epidemiology studies external exposures and diseases, this one, a new one, is aimed to detect biomarkers of genetic susceptibility or some genetic markers of a disease. Okay, it can be biomarker of exposure. It can be some changes that are identified early, very early, at early stage of disease. So then we have biomarkers of disease. For example, early biological effects or the altered function, but we don't see it in clinical situation. We can identify it by biomarkers. And of course, molecular or genetic epidemiology can become a very helpful tool of preventive medicine and clinical medicine. For example, to help a physician to give some, to make some precautions even before a clinical manifestation, but while there are already markers of susceptibility. Okay, the last question which we will discuss in today's lecture is about biases, okay, or what we call false association or spurious association. So one of the main problems in any epidemiological study is a systematic error that is a result of a wrong design. Many situations showed that it's a result of inappropriate design. Bias can be the result of not correctly collected data, or interpretation of data is not correct, and this all determines what we call validity. So validity of the study is not the same in a clinical trial and in a cohort study. But even in every particular study, we can identify biases, and biases can be differential or non-differential. And we will describe some of them, which are the most typical. So the typical bias which we have to discuss is called recall. Recall bias means subjects don't remember well what you study. Okay, for example, you study risk factors for congenital defects by case control study, and your cases are infants with congenital problems, while your controls are infants without congenital problems. And we conduct personal interviews to when we try to ask and to find out from mothers, yeah, what kind of risks they had in the past. So recall bias means that the subjects sometimes remember the previously happened exposures in a different way. And what we know typically is that cases remember better the past exposures compared to controls, because psychologically people blame themselves of the certain problems, and they try to remember what kind of exposures they could have in the past that led to this problem. So this is called recall bias, and recall bias is really very typical in a case control study. Another one is called reporting bias. Reporting bias can be in any study design, but usually reporting bias happens when you ask something very personal or something very private, yeah, or information that people find they're sensitive, yeah, to these questions. Let's say if we investigate relationships between syphilis and number of sexual partners, we use case control study, and we ask 100 of women with syphilis and 100 of controls without syphilis about the number of sexual partners in the previous 6 months. It can happen that cases will not report about the number of sexual partners because they know that they have a disease which is sexually transmitted, while controls, they don't think even about this, and they will say, they will give true information. So this is a typical reporting bias. Reporting bias can be on questions that are presenting some anxiety, some kind of some kind of maybe poor confidence of people, and usually this is very typical kind of bias in all study designs. So we say that case mothers report significantly more exposures to potential risk factors during pregnancies compared with control mothers. Another type of bias is called selection bias. Selection bias, it starts at the level of selection of subjects, and typical selection bias happens when in a prospective study we select exposed people and non-exposed people, and if we know that the risk of outcome is different, the reasons can be absolutely different related to exposure itself. So then in selection bias, we can select some subjects, for example, in a prospective study, which are unexposed, but they have specific characteristics, or they are exposed, but they also have specific characteristics. And in a case control study, we usually have selection bias when cases and controls are selected in such a way that probability of being exposed is different. And at the same time, reasons can be different than those related to the outcome. So to avoid selection bias is really very difficult. We will have to make subjects very similar in terms of characteristics when we have a case control study. And to prevent to prevent selection bias, we must check that our selection is based only on criteria of outcome. One more type of bias is called response bias, and it's the matter of different response. So to evaluate this problem, we have to assess the rate of response, and we must compare the baseline characteristics of responders and non-responders, because if we see that the characteristics of subjects are different, we can expect that response rate will be also different in different groups. So usually we try to do everything to obtain information of people who are not responders. And if possible, we will compare the answers of respondents with answers of non-responders. Though technically it's difficult. The next one is called selective survival bias. This is something very special when we have the study particularly long in the period of time, and if we have some assessment of the outcomes, we can have a group of subjects that have survived, and they are different from those who have died before. So this is usually happening when we construct 2-by-2 table, and we estimate each cell for the table, measuring risk of death for patients exposed and non-exposed. And to minimize this selective survival bias, we have to remember that how many subjects dropped out, how many of them died, and to check if those people who are present in the end of the study, are they actually similar to those who were in the beginning. Particularly, this problem is large if you have poor follow-up and there are a lot of dropouts. So the next one is selective migration bias. It is similar to the previous one, but people do not die, they just move. And for example, if we have a lot of people who move from your study and they are removed, and if they are different from those who are left, we have selective migration bias. So again, similar to selective survival bias, in selective migration bias, we have to check people remaining in the population and to check the cells for the table, either they have made a lot of difference compared to the previous baseline characteristics. The next one is follow-up bias. It occurs when the people who are followed up differ in a systematic way from the source population or original sample enrolled in the study. This is a problem in cohort studies and less, but still a problem in some clinical trials if people tend to give up participation. The next one is called prevalence incidence bias. Usually we can misunderstand the data, either it is a prevalent or incident data. Particularly if there is a change in exposure status after diagnosis, and the prevalence data can produce us different impression of association between exposure and outcome compared to incident data. In most of cases, this problem is typical for case-control studies or cross-sectional studies. That is why we must be careful when we have estimation of a risk in these study designs. So prevalence and incidence biases, they are also important to prevent. Here, just example, when we have incident cases in a defined population and we have prevalent cases present at a point in time, and we have during the follow-up early deaths, cures, and severe cases. So we have to be careful about incident cases and about prevalent cases. They are not the same. One more is called detection bias, when we have exposure that produces different probability of detecting a disease of interest. And if exposed individuals are more likely to have the detected disease, the risks estimates will be not true. They will give us false estimation. For example, when we study estrogen use and endometrial cancer, detection bias may result from more surveillance of estrogen users compared to non-users, because estrogen use tends to cause vaginal bleeding. And because they are under follow-up, we will have situations that when detection will be better in people who have potential exposure. So controls should be selected from gynecological patients who are subject to similar surveillance as the user. Membership bias, it's also a type of bias which occurs when controls are selected from a group in which a membership implies a certain risk of disease. That is different from the parent population from which we selected cases. For example, when we have a group of employed people or joggers that have some specific characteristics that are not typical for other subjects. One of the types of this membership bias, but typical for medical research, is called Birksonian bias. Usually it means that we select patients from the hospital setting, and usually in a hospital setting, patients have more severe situation compared to outpatients. And let's say if we study patients from hospital setting, they will have a situation of a disease that is more severe compared to other participants, and we will overestimate associations. Так, okay, well, so now please, I would like to show you just a short video about epidemiological studies in order just to summarize these questions, and I think you will understand it better.
Hello, and welcome to this video on epidemiological studies. We're going to have a quick look at epidemiological studies. What they are, a few different types of studies, their advantages and disadvantages. First of all, what is a study? Well, simply put, a study is a scientific process of answering a question using data from a population. It can be any question. For example, does smoking cause cancer? Is there more disease in an area compared to another? Or what food is responsible for causing an outbreak? So the first thing to do in any study is to have a study question. What are we trying to find out? Then we need to figure out what the best type of study is that would help us answer the question. Once we've decided on a study type, we need to do the study, collect and analyze the data using a suitable statistical method. Then we need to interpret the results to make sense of it all. And finally, we need to report the results of our study. Importantly, all studies need to be done in an ethical way. Now let's have a look at a few different study types. An ecological study is a type of study where measurements like disease rates and information about exposures are made on a group of people. The groups can be as small as people in a house or as large as people in an entire country. It's important to remember that results and conclusions from ecological studies apply to a group and not to individuals. Ecological studies are useful for comparing the health of populations in different places, such as measles rates in Australia and New Zealand, or at different times. They're also useful for generating questions and highlighting issues that can lend themselves to future investigations or studies. A case series describes the characteristics of a group of people who have the same disease or the same exposure. The aim of this is to understand the demographics, clinical presentation, prognosis, or other characteristics of people who have a particular disease, or describe something unusual. For example, in the early 1980s, the occurrence of an unusual pneumonia in men led to the recognition and identification of HIV. A cross-sectional study takes a selected population and measures health information at a given point in time, giving a snapshot of their health. It usually involves asking participants a series of questions using a questionnaire. Health surveys that collect health information about people in a population is an example of a cross-sectional study. Because these studies commonly measure how many people have a disease at a particular point of time, they're also called prevalence studies. It's important to make sure that the selected population is representative of the total population. Cross-sectional studies are relatively inexpensive and easy to conduct compared to other studies. They can provide information on multiple exposures and outcomes and are a good way of assessing the health needs of a population. However, because the information is collected at a single point in time, it cannot be used to determine whether a particular exposure caused the disease or not. A case control study starts off with cases. These are people with a disease. It uses a comparison group called controls, who are similar to cases but do not have the disease. Then both groups are asked about their previous exposures to different risk factors. Now, for each of the risk factors, the odds of being exposed if they were a case is compared to the odds of being exposed if they were a control. This is called an odds ratio. An odds ratio of more than 1 means that people with the disease are more likely to have been exposed to that risk factor than people without the disease. This suggests that it could be a possible cause of the disease. An odds ratio of less than 1 suggests that it's a protective factor, and 1 suggests no association. Case control studies are commonly used in food-borne outbreak investigations. For example, we can compare the odds of eating different kinds of food between people who fell ill after consuming a meal and those who didn't. If the odds ratio is greater than 1 for a particular type of food, then it's possibly the cause of the illness. A major advantage of a case control study is that they're often quick and cheap to do. Also, because they start off with cases, it can be used to study uncommon diseases. However, because these studies involve small numbers, they're not good to study rare exposures. One of the challenges in a case control study is to find suitably matched controls. Also, because studies ask about exposures in the past, people might not be able to recall their exposures accurately. Let's have a look at cohort studies now. In a cohort study, a group of people is followed over a period of time to see what happens to them, and information about risk factors is collected. We can then compare the occurrence of an outcome, like disease, in those who were exposed to a particular risk factor to those who were not exposed to that risk factor. The main measurement used in cohort studies is called the relative risk. A relative risk is the ratio between the risk of disease in the exposed group compared to the risk of disease in the unexposed group. A relative risk of greater than 1 means that the exposure is associated with an increased risk of the disease. If it is 1, it indicates that the risk is the same, and if it's less than 1, it indicates that the risk is lower. A well-known cohort study is the British doctor study, done in the 1950s, where a group of doctors were followed up for many years. This is useful when trying to determine what caused a disease. Another advantage is that information about several different outcomes and risk factors can be collected at the same time. This allows for sub-analysis to be conducted on the data. A disadvantage of cohort studies is the high cost, as they can involve a large number of people being followed over a long period of time. They're generally not suitable to study rare diseases. A challenge in cohort studies, especially ones that are conducted over a long period of time, is ensuring that people who started the study stay until the end of the study. If many people drop out, it will affect the results of the study. Now let's look at another type of study, an interventional study. In an interventional study, an intervention is done on a group of people and the outcome studied. Examples of interventions can be giving a medicine, a vaccine, or health advice. The outcome can be things like a change in disease status or change in behavior. A randomized controlled study is the best study design for an interventional study. Say we want to study the effects of a new drug. We start off with a study population. People are then randomly allocated to be in the intervention group, where they receive the drug, or in the control group, where they don't receive the drug. Then, after a suitable time period, the outcomes in the two groups are assessed and compared to see what effect the drug had. Outcomes can be things like a change in disease, symptoms, or death rates. Ideally, neither the participants nor the investigators should know which group received the intervention. This is called double blinding and ensures that neither of them can influence the outcome of the study. The main advantage of a randomized control study is that it can provide good evidence that the intervention led to an outcome. Randomization ensures that both groups have an equal chance of receiving the intervention and that they have similar characteristics. This way, the effect of the intervention can be determined without other factors influencing the outcome. The disadvantages are that these studies are generally quite expensive to do. It may also require suitable in some situations or unethical. Finally, sometimes it's hard to keep up with all the studies that have been done on a particular topic. But thankfully, there are studies that summarize other studies. There are two main ways that this is done. A systematic review systematically identifies all the relevant studies on a particular topic, assesses the quality of each study, synthesizes and interprets the findings, and presents an impartial, unbiased, and balanced summary of the evidence. A meta-analysis uses data from all the studies that have addressed the same question and have a similar study design. It then uses the data from these studies to do a combined statistical analysis and produces a single summary result. And that's an overview of some of the commonly used epidemiological study types. We've had a look at what a study is, different study types, their advantages and disadvantages.
Okay, so I hope you got the overview of this topic. So just to summarize and to finish, I have really to mention meta-analysis and reviews, which are today recognized the most reliable source of information which we use for evidence-based medicine. And the techniques of risk assessment and the study of associations will be our topic for the next lecture. Okay, so today I don't start because usually it's the topic number 3 for lecture, and we will discuss how to measure risk, how to study associations, and to investigate either it's a causal association or not, a true one or spurious one. This is the topic for the next lecture. So today we can finish. I must say that we, from today, from March, yeah, we have to give the link to the lecture, which will be available for 2 days in the Moodle platform. Okay, so it is done in order those students who find inconvenient to attend lecture, they can use this link and watch the lecture, but it will be recorded in the Zoom. Clear? Yes, I think you know it's for all departments. We got it. So after I finish lecture, I will put the link to the video in the Moodle in our platform, yeah, for public health. Okay, any questions maybe? Okay, if there are no questions, then we can finish. Okay, thank you very much for joining and for participating. So, до свидания.
До свидания.
Madam, до свидания.